right. Welcome, everybody. Thank you for joining us today. We're going to have you muted out in the audience at this point in time, just to maintain control over our time window, because we don't want to keep you over the time that we expect. We should be done in about an hour, leaving about 15 minutes for any questions. But during the presentation, we want you to type your questions in the chat box. Father Jeff is here, and he will be monitoring the chat box and be fielding the questions over to us. We're going to be flip-flopping from the screen to video, back and forth here and there. Just know that Dr. Matthews and I are not very tech savvy, and so we may have some glitches as we move along. There are handouts that are for this week. You're not going to actually use them. We will be doing a complete presentation, but you have, do you want to give me a picture here for a minute?
Well, I think speaking of those technical difficulties,
we're
trying to.
Because the camera is, we're not using the speaker on the camera, we're using on there. So
I see.
If you want to see you up there, I have to turn this off, and you have to mute yourself on that.
Don't want to do that.
Well, you can, yeah. So you'll turn the volume on there, and I'll mute myself over here.
Yeah.
All right.
So
How are we now?
Turn your volume on.
Yeah. Hold on. Technical.
Okay.
Can you hear me now? Give me a thumbs up, people. Can you hear me? Yeah. Okay. All right. Excellent. We have a lot of information to cover this week, this particular session. There are handouts, the Advance Care booklet from Beebe Hospital. This is nothing that you have to complete during today's session. You're going to start working on this outside the session. There is also an Advance Directive in the package, and you have the St. Peter's end of life booklet. All of these things work together with what the information is that we are going to be providing to you today.
They can be picked up in the office, or we can send me an email and I'll send them.
You can pick them up in the office at St. Peter's, or they will mail them to you. Just let Father Jeff know by email that you need that.
Yep.
All right. So let's get started with our centering prayer. So you're going to take me back to our slide.
All right.
Let's take a moment and rest in the presence of God. Heavenly Father, we come before you with the foreknowledge that the lives you have granted us lead through death to your gift of eternal resurrected life. You have given us the commandment to love one another as you have loved us. Through this love, help us to fulfill our obligation to our families through prayerful dialogue and these preparations. Be present, Lord Jesus, as we contemplate our mortal nature with the assurance of your presence throughout our lives. Amen.
Amen.
So I'm going to introduce myself. Some of you may already know me from being on the altar at St. Peter's now and again. I am Reverend Deacon Paula Waite. I am a staff chaplain and board certified as the hospital chaplain at Beebe Hospital. And I am joined today with our palliative care physician at Beebe Hospital, Dr. Sarah Matthews.
Yep. So I'm Sarah, and I am passionate about palliative medicine. We're going to talk more about what that is later on in our program.
Absolutely.
And I know Paula goes by a lot of different names, but if I'm calling her Chaplain Paula, that's because that's how I work with her in the hospital.
Correct. And she's always Dr. Matthews, so you got that, or Dr. Sarah. So just know that although you guys know me as something else, I am really just Chaplain Paula. Let's take a look at the program outline as we move through these upcoming weeks. Today, we will be starting with our advanced care planning, which is a lot of medical technology that we're going to have to speak about.
Yep.
Next week is how to talk to your loved ones. One of the most difficult things that we have found in our experience as hospital and healthcare is it's very hard to talk about this stuff. Our society does not talk about death. It's something very, we're going to hide it as if it doesn't exist.
Yeah, it feels scary.
Exactly.
And we're not really taught how to do it. We don't have practice.
Exactly. So we're going to teach you how to do that. Week 3 will be the Episcopal Church and end of life planning, talking about funerals, all the different things that go along with that. Week 4 will be our settings of care, including hospice and bereavement information. Again, that week, I will warn you that week 4 generally runs longer. There's a lot of information just like today. So plan, if you are attending all the sessions, to allot at least an hour and a half that day.
Yep.
And then the final week is with an attorney who will talk to you about your last will and testament and distribution of assets. That won't be Dr. Matthews and I. We will step out at that point and somebody else will take over.
Yeah, we don't do the legal financial.
No, we don't know anything about that. No, we don't. So, well, let's talk about why now? Why should we start doing this? And most people don't want to think about, you get very sick and all of a sudden you have to think about end of life. Well, that doesn't make any sense. We really need to talk about it before then. What are our values? What are our values? What are we concerned about?
Right. And I think a really important part of this whole discussion is normalizing these conversations,
Exactly.
Making it less scary by making it something we talk about.
Correct.
And a lot of my patients in the hospital will tell me that they're too young for an advance directive. They'll say, I'm too young to think about those end of life wishes. But that being said, the younger, more relatively healthy you are, that's the right time to think about it. When it's not an emergency,
Right.
When your family doesn't have to make those decisions for you because you're too sick.
Right, because the unexpected can happen at any time.
Yeah.
I mean, we know that. We've seen, this past year with COVID has been very difficult, but, accidents and heart attacks and things can happen to someone, and you don't want this waiting for you. If the part of it is you get it done, put it aside, and then you don't have to think about it anymore.
It's peace of mind.
And plus the fact that for us, for you guys, for me, we're resurrection people. There is something greater than what we're doing here. So some of this is normalizing the fact that our faith tells us that there's another place that we're going. So part of that is good. The Advance Directive piece of this is our method that you will do that will tell others what your wishes are. And it's not just I want to be buried here, or I want to whatever it is. It is literally saying, I want this particular care, or I care about quality, or I care about this. So it's very important, and that's what we're going to walk through as we move through the program.
Yep, we have a lot of information to dive into.
Exactly. So we do find them, we call them healthcare decisions, but it really is values.
And we're going to keep coming back to that this whole presentation. We're going to talk about, that's why these are important individual decisions for individual people, is because it all comes back to your values, who you are, what's important to you.
And it really isn't what's the matter with you. It is what matters to you. What is it? Is it a grandchild that's going to be born? Is it a wedding? Is it some specific trip? Is it something important that really is on your bucket list?
Yep. Yeah. Or living independently.
Indeed. That's a big one, right?
Yep, that's a big one.
We're really going to talk about that. So you've got an advance directive, and I'm going to, Sarah, step in here.
Yes, absolutely. So an advance directive really has two important parts, and we're going to talk more about that. The first part of an advance directive is, who would you want to make your decisions if you couldn't make them for yourself? And it's actually very nuanced, and we'll talk more about how do you pick the right decision maker.
Indeed.
And then the second part is about your actual healthcare wishes for yourself. If you were very sick, what would you want done? What would you not want done? What kind of quality of life would be acceptable to you?
And it could be called a lot of different things, because this may be called a living will. That was an old terminology that was used.
Yep.
Durable power of attorney for the medical directive. Healthcare proxy, all of those names is still an advance directive.
Yes. Yep.
Okay.
They all mean the same thing.
Okay.
And I think something that people may or may not realize is that the default in our healthcare system is to do all aggressive care that's possible.
Yes.
So if we don't have someone's wishes written down and we don't have someone making decisions for them who knows what they want, then we will do all aggressive things to them.
Absolutely.
And we'll talk more about what some of those are and why you may or may not want them.
Correct. Because some treatments that we might do can be helpful, but they can be also very harmful.
That's true.
So part of it is understanding what those treatments are and then saying, is this something I want?
Right.
Or
based
don't
on,
want.
Based on my values.
Based on my values.
Yeah.
You got it right. Exactly. So the point with our Advance Directive is that you can make choices for yourself as long as the healthcare, the medical team deems you have capacity. So that means if there's and you know, it comes up often, early onset dementia, some of the forgetfulness, the medical team is going to say yay or nay, whether that patient has capacity to even choose what is going to happen to them.
And capacity is one of those nebulous words. It's hard to know exactly what does that mean. The gist of what it means is, do you understand the options that are being laid out in front of you and the consequences of choosing one of those options? So as long as you're able to do that, you can understand the options in front of you, you can make your own choices.
Correct.
In healthcare, we always want people to make their own choices.
The patient always comes first. When you step into the hospital, it's about the patient. It's not about the family's wishes. It is about your wishes as the patient.
But that being said, a lot of times when people are extremely ill, they no longer have that ability to make their decisions.
Correct.
Whether they might be confused, they might be unconscious, they might be on a ventilator. And so that's why we're talking about this Advance Directive as a way to document your wishes if you can't tell your medical team about them yourself.
Absolutely. And the dilemma becomes, if you do not have this person designated, if you have not done it, the medical team at the hospital will follow the law of the land. And that law of the land is, there is a hierarchy.
Yep. So every state is different. Every state does this a different way. I actually come from California. And in California, it's totally different. In California, the medical team picks the person who they think has your best interest at heart.
Wow.
And there, it can be anyone. It can be a good friend. It can be a neighbor. It's variable. In Delaware, we actually have laws that tell us exactly who it is. So on the slide, you can see the first person it would be, if you haven't designated anyone specific, would be a spouse.
Automatically.
And that
is
legally married.
It's legally married. And so that means it doesn't matter whether you're a husband and wife or two wives, two husbands, you have to be legally married in order to be that spouse.
Exactly.
All right? You can't be a common law, nothing like that. Legally, you have to be married.
Right. And that comes into play because some of our patients may have been in a relationship for 40 years.
Correct.
But if they don't have that legal ceremony and legal piece of paper, then in Delaware, at least we go right down the hierarchy to the next person.
Which could be a family, which would be an adult child. And that's where it gets sticky in the hospital. It's because I could believe that I've been living with this man and he's my guy and everything else, but I come in the hospital, I have nothing to document that. He's not going to have a say so.
Exactly.
It's going to skip right over him.
And if it goes to the next one, which would be adult children, it's not just one child, it's all of the adult children.
And everybody has a voice. That means you have 6 kids. 6 kids have to agree unless you designate one voice.
And then, and something we see there is some people have children that may be estranged. Maybe they haven't spoken in 20 years, but legally that's the person we're going to go to.
Indeed. And that causes problems, I can assure you. And especially, it's not even the estrangement, it's the distance. You know, I might have a child and that child lives in California. How does that person really adapt and talk to the medical team as far as what the care is?
And then, as you can see on the slide, it goes down the list. From there, it would be if you have living parents, they would be next. Adult siblings, then grandchildren, nieces and nephews, aunts and uncles. And then
you have some circumstances.
So if if we go through this entire hierarchy and we can't find either any living family members or any living family members that are willing to do this role of decision maker, there are cases where a close friend can do it, but they have to go through special paperwork and have a notary.
Exactly. And that is important because we do that at the hospital.
Yep.
We do major searches. We will try our darndest to find a family member, but sometimes that just doesn't happen.
Right.
And so it can happen. It can be designated for somebody else, but it's just there's levels to get there.
Mm-hmm.
And that's why having an advance directive,
Yep.
we don't have to get to that point.
Yep.
You've already put it down in paper what you want.
Yep. And the very last step would be actually applying for a guardian, which would be a stranger through the government who was legally assigned to make decisions for you. And it takes months. It's very challenging to do. So basically, you don't want a guardian.
No, you don't.
Yeah, you want an advance directive.
You want an advance directive, very much so. So we're going to move into now some of the treatments that go along with that aggressive care that you need to think about your values.
Right.
And the first one is CPR.
Mm-hmm.
And the one piece about this is that it's not like on TV, people.
No, unfortunately not. So CPR is what would be used if your heart stops beating and you pass away.
Yep.
And a lot of people don't realize that either. They think you have a heart attack and then you get CPR. It's really only if your heart isn't beating.
Yep.
So CPR includes chest compressions. So that's pushing on the heart to physically try to restart it. It includes electric shocks of the heart. Yep. And it includes putting a breathing tube down someone's throat and putting them on the breathing machine to breathe for them.
So right at that point, you are on life support.
Yes.
You are on life support as soon as they put that breathing tube in.
Mm-hmm.
And this chest thing, I do talk to my families at the hospital, and it's one of the most difficult conversations we have to have. But CPR is not this. CPR is literally pounding on someone's chest. They have a machine that pounds for them if they can't do it for an extended period of time. Many times it breaks ribs.
Mm-hmm.
Many times the person, it's violent. I mean, bottom line is it's violent.
It is. And a lot of times it results in things like brain damage, because when your heart stops beating, you can't get oxygen to your brain and to the other organs that need it. I think it's really important too, like Chaplain Paula said, it's not like the movies. We've actually done studies, and the majority of people think that if your heart stops and the doctors and everyone try to restart it with CPR, people think, 75% chance that you're going to survive and go back to your life again. In reality, it's less than 10% chance of surviving, of even getting your heart restarted to the point that you're going to make it out of the hospital alive.
Less than 10%. I mean, that's scary, because I know that just recently, even that gentleman, he collapsed. His wife tried to do CPR, but didn't have the strength to do the pressures that are necessary to keep that heart beating. And so the body started shutting down, and it's very hard because brain damage is one of the first things that occurs. Because even with the machine on you doing chest compressions, the blood flow is not sufficient to saturate your brain, and the brain is the one organ that does not repair itself.
It's true.
So once it gets death in it, it can't come back.
It's true.
Yeah.
And we'll talk more as we go through about how you make some of these choices, and is CPR right for me or not right for me, which is going to come back to the values again.
Exactly. Now the next piece is what we call intubation, and that is this literally a breathing tube that goes down the throat. There's a machine that is breathing for them. It is life support. Now, a lot of patients, we might have to, if you have an open heart surgery, you would automatically be on a breathing machine because you're in the surgical operating room. There's a time lag. We don't want to keep you saturated. You would be able to come out, and they would remove that, and you would go on with your life.
Yes. Yeah, so I think it becomes very important when we're thinking about intubation and mechanical ventilation, that means going on the ventilator. Is this a short-term intubation because we can reverse something, we can fix something? A good example would be someone who has a very severe asthma attack and their lungs can't breathe for themselves because everything's constricted with asthma. And maybe they go on the ventilator for a few days, we get the lungs to relax and they can come off the ventilator.
Yep.
That's a very different situation from, for example, someone who is dying of end stage COPD, where they're at the end of their life in terms of their lungs. If they go on the breathing machine, the ventilator, unfortunately, we can't get them off again because there's nothing reversible.
And that's one of the hardest things, and that's why we keep going back to values. Because somebody with end-stage COPD, using that example, those people, there is nothing we can do. We can't bring them back. The lungs, scarring on the lungs is so significant. There's nothing we can do. And that person, if they have not made that decision, we would put this breathing tube in them, and that person would live whatever life they had left on that machine. They would not be able to communicate. It is very uncomfortable. We have to keep them sedated. So it's not, that's something you got to weigh when you're looking at what about that, you know, understanding your illness part of it.
Exactly. Yeah. What is your condition and what are your values and what will these treatments do for you?
Exactly.
So,
Yeah.
Another section on Advance Directive, another medical treatment to think about and talk about is artificial nutrition and hydration. So essentially we're talking about feeding tubes.
Right.
And this means if someone comes to a point where they can no longer eat by mouth, do they want to have a tube placed in their belly to have liquid tube feeds feed them for artificial nutrition?
But the problem is it can sustain someone's life, but it doesn't cure the illness that brought them to that point. So part of that is weighing, is that the way you want to live your life? Because there's risks associated with those tubes, right?
There are.
I mean, not just an infection.
So I think this is another case, kind of like the ventilator, where there might be sometimes it makes sense to get a feeding tube. For example, something obstructing the mouth, the esophagus. You physically can't eat, but you're not dying. You're not at end of life. A time that it doesn't make sense to put in a feeding tube is when someone is dying. For example, if someone's has a stage 4 cancer and is dying to the point they no longer have the strength to eat and drink, then we see that when people in that situation get feeding tubes placed, their body doesn't know what to do with all that liquid and that tube feeds anymore. And a dying body doesn't need those things.
Correct.
So the fluid can back up in their lungs, in their legs, they're very swollen, and it can be uncomfortable.
Well, and that's the one thing, is that people think that at the end of life, oh, I'm going to starve my loved one to death if I don't put the feeding tube in. But at end of life, our bodies start saying to themselves, we don't want to eat anymore. We are leaving this world for another world. So sometimes we find family members have a very difficult time understanding that it is not something that, it is a natural death,
right,
to that you stop eating. And I know even with me, my mom in the last week of her life, probably more like the 2 weeks, she stopped eating because she had end stage Alzheimer's disease, and she no longer had the desire to eat. And so it wasn't that we were starving her, it's she did not want food anymore.
It's part of the natural process her body was going through. Just a few more notes on the artificial nutrition and hydration. So IVs can be placed in people's veins and their blood vessels to have fluid flowing through because they can't drink liquid anymore. And like we mentioned before, sometimes it makes sense to have what we call a time-limited trial. And that means maybe we can try this for a little bit and see if it helps or if it doesn't help. And if something doesn't help, then maybe it doesn't make sense to keep doing it long term.
Exactly. And you know, that's the one thing that we talk to the families and when we have family meetings, and Dr. Matthews and I constantly are having family meetings, and sometimes the family members, again, if you've not voiced your values, what is important to you, families will feel like, well, we ought to do this, we ought to try, we ought to do this. And it can be very, very difficult to stop a treatment once you've initiated it. And if it's an end of life scenario, putting a breathing tube in or putting the feeding tube in and then having to make a decision a week later that the person is dying anyway, and then it feels like the horrible line, which no one ever uses, pulling the plug. And that's a horrible thing that used to be used. But it is very difficult to stop once you start it.
Right. And I think that's why we're really encouraging people to think about these wishes ahead of time, to prepare instead of react in emergencies.
Correct. So it really is, we're going to come back to this again, that what really matters, it's not the medical, it's not the legal, it's not ethical. It really is emotional and spiritual. It is about us being resurrection people and saying, I want to do what I can do, but I don't want to just take it from my, here's the book, it says I can do all these things. Is that really what I want to do? Yeah. And here we get to the tough part. So the things to consider at the end of life is, do you want your life prolonged as long as it is possible? If you are at the end of life or you're permanently unconscious, and we call that a coma or persistent vegetative state. This is something you have to think about, whether it's a loved one or whether it's yourself. Thinking about, do you want to live on machines? Is that life to you? Is that quality of life to you? We can do amazing things in healthcare, amazing things. And we can keep people alive on machines for a long time. But is that quality of life?
And as we get closer to end of life, a lot of time there are trade-offs.
Yes.
And a lot of times, unfortunately, that trade-off is quantity of life versus quality.
Absolutely.
And sometimes at a certain point, choosing to continue all of the aggressive measures means spending all of the rest of your time in the hospital.
And that's an important piece, isn't it, Sarah?
Yeah.
Yeah, it really is. We have a lot of people, we can do a lot of these things and keep things going, but you will end up, the person will end up being in the hospital, not in their home, not with their family. And certainly right now, as we continue following pandemic, we're not letting visitors come in very frequently in the hospital, and it's a very limited. So if somebody had made decisions like this, they could be living alone in the hospital. Like you all probably, I'm sure you've heard about it, that we lived through last year with pandemic, of families not being able to come in. And so these people died with me and Dr. Matthews instead of their family. So part of this is thinking about, why do I want that? And where am I going to receive that type of care too? Yes.
This slide, it's really just a list of possible conditions when a patient or a family might say, I no longer want some of those aggressive life prolonging treatments. And like we talked about before, it's really about values. But these are just some examples. If someone knows they have a terminal illness, they might say, I don't want to go on the breathing machine at the end of my life. If my heart stops, I want to be peaceful. Some other possibilities would be the permanent vegetative state, like Chaplain Paula said. We see that a lot of times after someone's heart stops.
Indeed.
When people have brain damage.
Correct. And that is, when we see that brain damage, we are able to actually identify whether that person's going to come back. And a lot of the dialogue that we have in emergent situations is helping family members understand your loved one has suffered a devastating scenario where they will never come back to be the person that you knew and loved. And trying to explain that is very difficult. And that's why let's take the fear out of this and talk about it.
Exactly. Yep. And then some other potentials would be someone who's very sick in the ICU and comes to a point where multiple of their organs are shutting down. We see that a lot. You might come in with one issue. For example, you might come in with pneumonia, but if you come to a point where now your kidneys are shutting down and you're having heart failure, for some people that might be a point they wouldn't want the aggressive things anymore. And then also, like we talked about before, if we've been trying some of these aggressive life support measures and they're not working, if the person unfortunately is not getting better.
Yeah. And I think that's, again, that hurts our hearts when we talk about that. But the reality is that we've exhausted, many times we exhaust all of our medical alternatives. And we have to face the fact that this is our temporary home.
Yep.
And we're going to move on.
Yep.
Good. Good.
So as a recap, so back to what we're talking about is advance directives. Okay. So an advance directive is a document you fill out to record your wishes to help, in the future in case you can't speak for yourself.
Correct.
Okay. It has two parts. The first one is naming a decision maker. That's the person you want to make your decisions if you can't make them anymore. And the second part is documenting your healthcare wishes for the things you do and do not want if you are coming to the end of your life.
Right.
Okay. Advance directives in Delaware need 2 witnesses to sign them.
Yeah, this doesn't have to be notarized. This can be just witnessed by people. It cannot be a family member that witnesses on this, okay? So when you start working on some of the paperwork at the end of all these classes, just know that you can have friends witness. They don't have to see what your choices are. They're just witnessing the fact that you are signing that document.
Yep, exactly. Okay.
Now let's talk about how do we pick that person?
Well, okay, so now we're going to talk about some other pieces of it. We have the advance directive. So the durable power of attorney, that means the same thing as the surrogate decision maker.
Yes.
So we use a lot of different words to mean the same thing.
Yes.
So sometimes there's a power of attorney form, and that would name the decision maker without having all the wishes and the rest of the pieces in the advance directive.
Well, and there's that little glitch, just to keep them clarified, is that you can have a power of attorney for your assets and for your home and things like that. That is not the same as your power of attorney for healthcare.
Exactly.
It could be 2 different people. It might be the same person, but it is very specific that you are designating someone who is going to speak for you when you cannot speak for yourself.
Yep. Yep. So in terms of how do you pick the right person to be your surrogate decision maker? Well, they need to be an adult right off the bat.
Exactly.
You can't choose a minor. It should be someone who knows you, who knows your wishes, someone who can put in their judgment of what would you have wanted in this situation.
That's what we always say, we say in the hospital, because when we get to a scenario where we don't have somebody who's designated, the conversation for us when we sit down is, what would your loved one want? It's not about what you want. This person, it's not about their wishes. And that's part of the selection process, isn't it, Sarah?
It is.
Because you have to be confident that they're reliable, that they're going to carry out your wishes, even if they disagree.
Yes, yes. And we'll hear that from patients sometimes. They'll say, well, I love my wife, my husband, whoever it may be, but I don't think that they would honor my wishes. I think that they would, they would say, oh, my loved one didn't want to be intubated, but let's put them on the breathing machine because I can't let go.
Exactly.
And there's nothing wrong with picking the person who you think will follow your wishes the best.
Correct.
Yeah.
It's actually, and you really need to think about it that we don't want it to be a group of people.
Right.
So that goes back to that, in state of Delaware, if you haven't named anyone and you have 7 children, those 7 children have to come to an agreement about what your wishes are if you haven't stated them.
Right.
And there can be a lot of contention in those
Yeah.
Yes.
Yeah, the Advance Directive is not the time to say, I want to honor how much I love all my children by putting them, equally as decision makers. It's the time to choose one person who can be a spokesperson for the family and who can make those decisions.
Yes. Yes.
All right, we're going to talk about some other terms.
Yes.
So every time someone comes into the hospital, we ask about code status. And what code status really means is if someone's heart stops beating and they die, what do they want done in that moment?
And I think that that's an important platform that you just hit. If somebody's heart stops and they die, when the heart stops, they're considered dead. So what are we going to do about that?
Right.
Okay.
And so the question is, does that person want us to attempt CPR, to attempt to restart their heart, like we talked about earlier with the chest compressions and the electric shocks? Or do they want what we call DNAR, do not attempt resuscitation, which is essentially saying, if my heart stops, I want to pass away peacefully. I don't want you to do those chest compressions and shocks and put me on life support. I want you to let me go. So that's really what DNR means.
Yeah, it's allowing a natural death, right?
Yeah.
And a lot of times somebody might come into the hospital full code, which means we're going to do everything. But as their condition declines, or we identify what that condition is, whether it's end of life or whatever it is, they may change that. And when we talk about that with them to explain that, yes, we could do this. However, here's what might happen.
Yeah. And these are situational decisions. So you don't necessarily have to say, oh, I'm DNR all the time now. It can be specific to that situation when you're in the hospital.
Right.
Or in the Advance Directive, the wishes you're writing down are specific to certain situations.
Exactly.
If you have a terminal condition, if you're permanently unconscious, etc.
Yes. If you've been determined to meet criteria, that would go into effect.
Yeah.
And this code status is really only appropriate or realistic within the healthcare setting.
Yeah.
It doesn't have anything to do with what happens in my house.
Well, we'll talk about that.
Yes, I know.
Wow.
We got right there.
What a segue. So another important document with advanced care planning is a DMOST form.
Yes.
So this is the Delaware Medical Orders for Scope of Treatment. So a DMOST is a form that's filled out by your doctor or by other healthcare providers. And it's not for everyone. Not everyone needs a DMOST. Your doctors are determining if a DMOST is right for you. And the purpose of a DMOST is to help protect people's wishes across all different settings.
Okay. Yep.
So you were saying the DNR would be just in the hospital at that time, but someone might have a condition where they say, you know what, I always want to be DNR, or I always want, if my heart stops, to have a peaceful passing, either because of my age or because of my medical conditions. I know that that's what I want.
Yep.
So a DMOST form is something that you and your doctor would sign together, and you can document those wishes, and those wishes are a standing medical order, whether it's in your house, whether it's in a nursing home. It follows you wherever you may be to help protect your wishes.
And we literally, with the DMOST, there's something called the pink envelope, and you have to put it on your refrigerator, because let's say I've been released from the hospital, I have a terminal condition, I know I don't want all this stuff to happen to me. I want to stay in my house, I want to be with my dog and my family members, and if my heart stops or whatever happens at that point in time, even if somebody calls 911 to get the EMT to come, if the EMT walks in and sees that on the refrigerator, they're going to look at it and say, okay, this person has made this decision.
Right. Yep. This person wants their wishes to be honored.
Yes.
Yeah. So depending on someone's medical situation, they might have both an Advance Directive and a DMOST.
Yeah.
It's not an either or, they just have slightly different roles.
Okay.
Yeah.
And there is, with this standing order, I saw something in your notes that you had given me, Sarah. There is a criteria for this. If the doctor generally believes that the person isn't going to survive
So
past
so what we use is called the surprise question. And the question that's asked to the doctor or the other medical professional is, would you be surprised if this person passed away within the next year? So it doesn't necessarily mean your doctor only thinks you have 1 year to live. It means your doctor thinks with your conditions, something might happen within the next year where we would need to know your wishes.
So I'm going to use an example, no names, a young person who has stage 4 cancer. 37 years old. There's nothing we can do to cure it. There's no surgical option. There is nothing at all that can be done. The choice then is the only way for getting medications or whatever the case may be is to be in the hospital and to stay in the hospital. And for that person, that patient, it was very important to go home. That person was appropriate for a DMOST.
Yes. Correct.
So we wouldn't bring that person come back into the hospital.
Yeah, to help honor their wishes at home.
Okay.
Exactly. Yeah. So this is a description of some of the options that are on the DMOST form. So the DMOST form has whether or not you would want CPR if your heart stops beating. And then it has different options of treatment if your heart is beating but you're very ill. So on the DMOST, you can designate, do I want full treatment? That means you do want to go on the breathing machine, the ventilator. You do want to come to the ICU and go on life support. It's kind of the most aggressive option.
Yes.
There's another option for limited treatment. That would be for someone who's okay with coming back to the hospital. And they're okay with getting maybe, antibiotics or IV fluids, but they know that they don't want the life support and the ventilator of the most aggressive care.
Okay.
And then the last option on a DMOST is someone who wants comfort measures only. So an example might be someone who has chosen to be on hospice care because of their illness, and they really want the focus of their care to be their comfort. They don't want to go back to the hospital if they can avoid it.
Gotcha. And we're not going to jump towards hospice. We will be talking about hospice in a later session. So don't go there yet. Don't go there yet. But is that comfort measures only? We very questions. There's some questions as far as in the hospital. Many times when we have gotten a patient to a certain point and we recognize that they are not going to be able to leave the hospital, their life is ending, and we get to what's called we get to be what's called comfort measures, and we're doing the same thing, just making them comfortable.
Yep.
Right.
Yep. That's
Okay.
right.
Okay.
So Chaplain Paula,
Yes.
I know we've been very upfront that we're going to work out our kinks as we go. Do you want to answer this question now or save it for the end?
I think since we're at DNR, and I think we're time-wise, we're good time-wise, so
Go.
yeah, go ahead and answer that.
So we had a question from someone here. I'll toggle so you can actually see us. Let's do that. Okay. So thank you for submitting questions. We had a question regarding the do not attempt resuscitation. On that slide, we had some possibilities of why someone might choose do not attempt resuscitation.
Yep.
And so someone asked, why was 65 plus listed on that slide? Shouldn't it be 75 plus or an older age, given all that that we can medically do, at the 65 age?
Big question.
It's a big question. It's a good question.
It's a good question.
And I think I have a couple comments. I think number one, I think the number is not as important as someone's physical state and their values. I think that in our job, we see some very ill 65-year-olds and 55-year-olds. We see some very well 75-year-olds.
We sure do.
I think the other piece that's important is that, again, on TV, they show CPR as something that really works and really gets people back to their life. But unfortunately, the reality is that essentially the CPR is really only helpful if there's an accident that causes the heart to stop. For example, someone who's with a young, healthy heart is in a bad car accident.
Yes.
And so, by just pushing on that heart, we can get it going again and get them back to their life.
Yes.
In the majority of cases, someone's heart only stops if the body has severe enough conditions
Mhm.
that their body is dying.
Yeah. Yes.
So us pushing on someone's heart and trying to restart it is unfortunately very unlikely to
Well,
get
what, didn't you say it was like less than 10%?
less than 10%.
They're going to come back. And I'll tell you that in our experience at the hospital, we see all ages. You know, we have a 104-year-old
Yep.
in there. The body honestly cannot recover, regardless whether you are out there walking and doing everything at 75 and 80 years old.
Yep.
This CPR, this do not attempt resuscitation, this is, I cannot explain how violent it is. And the first time I had to experience it was very difficult for me. And especially because there's a machine that the EMTs will use. And this machine is, it cracks ribs. I mean, to get through to the heart, to get this to go, you need to break it out.
Right. Yeah. And so,
And coming back from that when you're older
yeah,
is unlikely.
right. Yeah. So it's a very low success rate procedure for most ages, to be completely honest. The older someone gets, the less likely it is to be helpful. The question you're really asking yourself with do you want CPR is, do you want to go through this aggressive intervention for the small chance that you might be the less than 10% that's even going to survive?
And that doesn't mean quality.
Well, the majority of people who survive will have brain damage.
Right.
So it's, are you willing to go through that for that potential outcome is
Right.
really what the question is. So hopefully that helped answer.
Yeah, it's a difficult, it's a challenge. And I know, again, we're resurrection people. We're talking about things that are very difficult. And that's why we're doing these sessions, because these are difficult topics. And this doesn't mean you can say, I want to be resuscitated and I'm healthy and I'm 80 years old and I'm healthy, and give it a try.
Yeah.
That's fine. But just know that the percentage of that person coming back as that same person is very slim.
Yes.
Yeah.
Okay. All right. Thank you for the question.
Thank you.
So let's go back to our slides. Okay.
The treatment, yeah,
Yep.
This is good. Yeah.
Go ahead.
So this goes back to your values, and all of these treatments that we've talked about, whether it's a feeding tube, whether all of these things, it's a good fit if it's going to relieve suffering. And that is one of the things that we do all the time in the hospital, is talk about suffering. If it's going to increase your quality of life and they're in line with your values,
Yep.
those are great reasons to do everything you can possibly do. But if they are not, if that does not fall into play, then you really have to think about what are these treatments for a serious illness. If I have been diagnosed, I have not, but I have been diagnosed with stage 4 cancer. I go in for my chemo treatment and it is worse than the cancer could ever be. And we find this repeatedly, unfortunately. I might make that choice. I don't want that treatment because I am sick all the time. I can't enjoy my family. I'm spending the time, throwing up or whatever the case may be. That isn't a good fit. So part of it is weighing your values and say, how do I want to go? Now, do I want to try it? I have a very dear friend, one of my high school friends. She had melanoma and she went in for the chemo treatment. She said, I cannot tolerate it. I cannot do this, and refused it. Well, she's only 65 years old, but she wants quality of life. She wants to be with her husband and her sons and all of that. And she's living out her values to whatever end that is.
Yep. The choices that are right for her.
Absolutely.
Yep. So like you mentioned, the chemotherapy, there are a whole plethora of different treatments that could be options in a serious illness.
Yep.
And I think that's another important point, is that when you have a serious illness, these are always options. Sometimes the medical team presents it as, oh, this is the next step, this is what we're going to do, but you're the boss of your own body. You get to decide, what you want and what you don't want.
And we want our patients to choose for themselves.
Yes.
Because there are some docs There's some docs that will say we're going to do all these things, and that may not align with your values. So part of it is advocating for yourself in your discussion with your medical team.
Yeah.
What are your values in that dialogue?
Yeah. And this slide is not to say that these are bad treatment options. You know, a lot of these will be very appropriate if they're helping you with your quality of life and your goals and your values. But just some examples that our patients have discussions and decisions about, things like dialysis, things like doing invasive tests when they're seriously ill. For example, should we go in and get that biopsy in someone who's very close to end of life?
Right.
Also things like pacemakers, defibrillators. Yeah.
Well, and understanding, and part of it is educating ourselves, isn't it?
Yeah.
You know, it's saying, well, what does dialysis mean to me? Well, dialysis means that for 3 days a week, you're going to be in a facility for hours on end, and that is how you're going to live out your life. And many people will say that that's not what they want.
And other people will say, I do want that.
Exactly.
And I don't mind sitting in that chair and, you know, I get my joy out of watching TV.
Right.
It's just different for everyone.
Exactly. Exactly.
All right. So
we're going to touch on that. We're going to touch on this, and from the expert of palliative care.
So I am a palliative care doctor. And
Sarah, can I ask that, I know that these guys have not, you know, they didn't get like a big explanation about who you are.
Yeah.
Sarah and I are fortunate that we hooked up with each other at Beebe Hospital. Sarah came from California where she was doing her fellowship in palliative care. Why did you go to this direction?
Yep. So, so I went into the field of medicine because I wanted to help people. I don't have any doctors in my family. I actually took a career aptitude test that told me I should be a doctor because I liked helping people and I liked science.
All right.
But as I was going through medical school and all of the wacky things we do as doctors in training, I found myself questioning a lot. Why are we doing this? Some of the things we do to people, is this what they want? Do they understand what this is getting them? And as I went on, I thought more and more about that. And when I discovered that there was a field of medicine, that whole goal is to get to know someone as a whole person.
Exactly.
To get to know their values, their family, their social situation, their spiritual situation, and to help them find care that lines up with all of that, with their goals. That was just the perfect fit for me.
Absolutely.
I felt like I need to do this kind of medicine.
Right. And most hospitals, I think, not all, certainly some of the smaller ones don't have it yet in place. We're very fortunate here at Beebe Hospital. We have a palliative care team. We have 2 palliative care physicians. Dr. Katie Johnson really resides down at Tunnel Cancer Center most of her time. She does home visits and goes out and works with people with chronic illnesses.
Yes.
Dr. Matthews is at the hospital. Also on our team are myself as a chaplain, our other chaplain, Chaplain Keith Goheen, is also on that. And we also have a patient advocate who listens in on everything and recognizes sometimes where we're going, might run into a snag with a family or have a challenge or whatever. So we try to build, the team is built to help the patient and the families as much as possible.
Exactly.
To get them to what their values are. Because palliative care, a lot of people think it's hospice, and it isn't hospice. It is totally not hospice. Hospice is, if you are in hospice, you're in the palliative umbrella. But you can be in the palliative umbrella and not in hospice. So don't, if it comes up in conversation, don't think we're sending you on your way.
Yes. Don't be afraid of palliative medicine.
No.
A lot of patients are. A lot of patients think palliative means hospice, like you said. But palliative medicine is really, it's a whole person approach. It focuses on symptoms. So I help patients with their pain, their nausea, their anxiety. I help them with planning for the future, thinking about, you know, what do you understand from what your doctors have told you, and what are your thoughts about these options and what's the best fit for you? Where do you get your joy in life?
Right, and you pull all the threads together, so all of the specialists that are out there funnel back through because you're treating the whole person at that point in time.
Yeah,
right?
and sometimes we act as a coordination of care, taking all these different pieces and these silos that may not communicate with each other and bring it to one big picture.
Right.
What does this mean for you? What does this mean for your life?
Yeah, because we have a lot of times at the hospital, we'll have somebody say, well, the cardiac doctor said this, and the urologist said this, and this one said this, and the patient gets very confused because there's so many voices.
Yep.
But with a chronic or illness or anything that needs care on a longer time period, we actually help make it better.
Yeah.
Yes, we do make it better.
Yeah. Oh,
So the point of these sessions, as you'll understand as we continue to move through them, you can keep thinking that I don't need to write this out today, I don't need to do it, but unfortunately the catastrophic can many times happen. So we are encouraging, we're taking our dog and pony show, and Dr. Matthews and I are going to be traveling throughout Delaware talking to people, because what we've seen in the hospital is really sad things.
Yeah.
Sad things where families are distressed, they can't make a decision, they don't know what to do, it's difficult.
And I think one of the most heartbreaking things is, as a medical team, when we're giving people care that we know does not line up with their goals, it's really sad and it's tragic.
Yes,
Yeah.
absolutely. So part of it is start reading. We're going to have lots of time for questions, and as we go through that, everything's going to fit together. The 5 sessions work very well together. You'll learn a lot this time. Obviously, this is a lot of material, and we do have, I haven't even seen, we are right at 4 o'clock. We are here for 15 minutes. We can open up the line. You can raise a hand if you have a question, and we're happy to answer that straight up. Wait a minute, got to get you unmuted. Give us a raised hand. It's probably in your bottom. Where's that little raised hand that you do?
It's down on the bottom.
So if you click the reactions, and then there's a button that says raise your hand. So if you do that, Father
Down
Jeff
at the bottom.
it's down at the bottom of your screen. And if you do that, Father Jeff will see that that you want to ask a question, and he can help you with unmuting.
All right, so Pamela.
So I see Pamela's hand is up.
Down one.
Oh,
right
maybe
there.
it went away. Oh, she's unmuted herself.
Okay.
Go ahead,
Go ahead, Pam.
Hi, thank you so much for this. We really
Pam, do you
appreciate
have a
it.
question?
A question and a thank you. I knew nothing
Maybe
about
she doesn't have
palliative
her
care.
speaker on.
Oh, I'm sorry. No, I'm not muted.
Pam, go ahead and text. You can put it in the chat box too.
Oh, crap. Okay.
It's not coming through.
Okay.
I don't know why.
We'll be back next week. You
Sorry.
can
You
hold
can
it.
type it in the chat section.
Yes, you can absolutely type it, anything in.
I'm trying.
There was something.
Oh, there's another hand. I think.
Yeah, Mildred.
Mildred?
Why not go ahead and
No,
let her
you can't
just,
hear.
I think it's your speaker isn't playing yet.
Yeah,
can't you just ask?
I could also unmute mine if that's.
Yeah, try that.
let's try
Will we
that.
get horrible reverb with the?
Why not let just Pam talk right now? Because we can hear her.
Now we can't hear her.
I'm not hearing anything now.
Oh, can you hear us now?
Yes,
Okay, sorry
Okay.
about that. We are not very tech savvy, but we can finally hear you.
So what's your question, Mildred?
I was just commenting that why not let Pamela ask her question, because we can hear it and it's relevant right now.
Oh, we just couldn't hear Pamela. We were having a lot of trouble with our speaker,
Oh,
but we're ready. We can hear Pamela now if she would like to ask her question.
Anybody can ask.
I wanted to thank you for this very much. Can you hear me now?
Yes.
We're so sorry.
Okay. Having been retired from the medical field for almost 20 years, I knew nothing about palliative care. This has been most informing. I'm loving it immensely. Thank you so much, Sarah and Paula.
Great.
Also, I have a question. In the Delaware area, how prevalent is palliative care? We live in Blades over in Seaford. Do you know if there's any other hospitals besides Beebe?
Yes, that's a very good question. So like Chaplain Paula was saying, palliative care is a newer field and it's growing as time goes on. So Christiana has a very large palliative program. I believe that Nanticoke Bay Health has some palliative nurse practitioners. Let's see, what else do we have?
It's probably, they have a very robust program up at Christiana, which is where I did my residency. I would call ours very robust because we have 5 people on our team. I don't think that Bay Health is as strong in it because they do have the nurse practitioners, but they don't have a staff of chaplains and other people that are involved.
Physicians. Yeah, it's a newer, younger program.
Absolutely.
We're closer to, Nanticoke is part of Tidal Health in Salisbury.
Yes.
Do you know anything about Tidal Health in Salisbury?
I do believe that they have a palliative nurse practitioner.
Oh, that's good.
Yes.
Yeah.
And this brochure, the paperwork will be available this coming week. Is that correct?
Yes. These, Father Jeff has these, which are already printed and you can just pick up either at the office or he'll mail them out to you. He also has these, which is the Advance Directive form. And so these we've already supplied. And then Father Jeff also has this book, which is the end of life. We'll be using this in week 3. And then again, we recommend that go through all the sessions and then sit down and start filling things in. That's
And
what
the sessions are being recorded so that we can watch them if we're not able to watch in person.
Yes, it will be on the YouTube channel tomorrow, and you can rewatch, you can share it, you can do whatever you want with it. And again, some of the forms, there are handouts that go with each week. And I think Father Jeff emailed them out, and just ask if you want them, because next week with the next session, there's other handouts that will come out for that. These will be your workbooks for the entire time. You can start looking at them, thinking about the questions, and we're happy to help with that too. So when you have questions about it, Dr. Matthews is, we're going to be back every week for 4 weeks, so you're stuck with us.
Thank you very much.
Of course. Yeah, thank you.
Anybody else?
You might just mention that if they go to the St. Peter's website, that there, and scroll down, there will be the YouTube link for them to go in and find this presentation.
Yep. Thank you, Rita.
Thank you.
Anybody else? You did pretty good. You stayed on time. You stayed on time.
Quick question.
Yep.
Yeah. We're not in a rush.
Recently retired and moved from the state of Maryland and had all of these. Do you know, I realize it's a different profession, but do you know whether Delaware will accept the same forms from the state of Maryland?
That is an excellent question, and I'm glad you asked it because that came up in our other session as well. So Delaware and all of the surrounding states have what they call reciprocity, which means all of them try to honor each other's documents. That's both the advance directives from different states and also the different states' version of the DMOST. So Delaware has the DMOST, Maryland has the MOST, and it's all the same document. But yes, the states do honor each other's documents.
Perfect. Thank you so much.
Of course.
Anything else today? Excellent. All right, we will be back here at 3 o'clock on the nose next week. Invite friends. We are happy to have a crowd. And if you have questions that haven't been answered, please feel free to send them along to Father Jeff. He and I connect with each other quite frequently, so I will hear about them and we'll make sure that we have answers for you next week if we haven't given them in the interim.
And we appreciate your participation. We appreciate you being here. We know this is hard to talk about, hard to think about. So you're doing a great job just being here.
Yep,
We
proud of
appreciate
y'all. Proud of y'all. Okay.
All right.
Thank
All right,
you.
thank you.
Have a good week.
And